Subhas Mukherjee used to work. Our physiology lectures used to be held next to the lab where he used to work. And he was born on 16th of January 1931, Indian scientist of origin, physician from Hazaribagh in Bihar and Orissa province of the erstwhile British India, now Jharkhand in India, who created the world's second and India's first IVF child. I think it might well be the first child, it's just that he hadn't documented things properly, and therefore he was not given the credit. He did his PhD from Rajabajar Science College, campus of University of Calcutta in reproductive physiology. We are fortunate that we are actually now a sister institute of the physiology department of Calcutta University, and one of my trainees is actually doing a PhD there as well right now. And he did a second PhD from the University of Edinburgh. He came back, he did his own LH, FSH assays, and I can assure you the room in which he used to do is so small, and I don't know how he managed to do all of that. And the work that he did, he used to scribble down on bits and pieces of paper. Unfortunately, when it came to presenting the data, nobody believed him. Poor guy, he committed suicide. Nobody gave him the accolades for the work that he had actually done. So let me invite our chairpersons to introduce Dr. Pinaki Dutta, the recipient of 2020 Subhas Mukherjee Oration.
A warm welcome to you, Dr. Pinaki Dutta, and congratulations for this honor. He is DM in endocrinology and currently Professor of Endocrinology at the Postgraduate Institute of Medical Education and Research at Chandigarh. Academic and clinical achievements and contributions, he has approximately 240 publications in peer-reviewed journals. So congratulations again, and
invite Professor Pinaki Dutta to deliver his oration.
So the title of my discussion will be Acromegaly from Phenotype to Genotype. So thank you very much, Endocrine Society, and all seniors and junior colleagues. So going to the history of acromegaly, it was Mary who described the disease initially. So it goes by the name as Mary's malady. However, there is enough description of acromegaly in the literature in the past also. You can find out it in a Dutch stamp, and the famous Italian painter Michelangelo also, who is otherwise known as Caravaggio also, he was himself acromegalic, and he has depicted all his pictures and photographs also, and you can find out what is the progressive change actually. And this is the AIP mutation in pituitary adenomas in 18th century and today by Professor Marta Corbonit. You can find out she is standing in the London Museum, and the skeleton of an Irish giant who was more than 210 centimeters, and subsequently she analyzed with the help of the German CFSL, extracted a tooth actually, and analyzed did the genetic analysis and found out the aryl hydrocarbon interacting protein mutation in the giant, and subsequently they had done a survey in the Northern Ireland and found out almost 67th generation of this subject was affected by the disease. So coming to the definition and problem statement, I am going to present whatever we had done in last 20 years in PGI and think this as an entertainment only. And even one of you is benefited, I am very happy. So this is an uncommon disorder and it occurs after the fusion of growth plate. It is known as acromegaly, and gigantism occurs before epiphyseal fusion. And this is because of chronic hypersecretion of growth hormone, and rarely it occurs because of exogenous growth hormone and IGF-1 misuse. The prevalence is almost 40 per million and incidence is 3 per million. This is our first paper on adolescent acromegaly. So in which we had shown that the common presenting manifestation included acral enlargement, tumor mass effect, and in female, menstrual irregularity was the main presenting manifestation, and the mean height at presentation was 174.6 plus minus 37.7 centimeters. So because the epiphysis is not fused, they presented with acrozygotism. And atypical features included presentation with polycystic ovary disease, cellular tuberculosis, I will show you. One patient presented with glioblastoma multiforme along with acromegaly. Concurrently, one patient presented with mania, one had differential growth of limbs because of paralytic poliomyelitis, very fascinating figure, and some of them had fibrous dysplasia. This is the clinical profile and outcome of our series of acromegaly, and I will show you how multidisciplinary approach leads to better care and better outcome. So in this study, total 271 subjects were, patients with acromegaly were there, and 134 were male. And mean age at presentation was 37 plus minus 12.5 years, and the lag period was almost 5 years. And height in adults was 167 centimeters, and in adolescents, I had already told previously, it was 176 centimeters. And predominantly, they presented in the actually third and fifth decade of life, in between that, and very few of them were there below 20 years of age. And coming to the etiologies, most of the cases, it was a pituitary adenoma only. Microadenoma were found in 6.6%. Mesoadenoma, I mean that intracellular macroadenoma was there in 9.6%, and most of them had macroadenoma. It was 83%. And last 100 patients we analyzed with, in whom the MRI pictures were available. 40% of them were NOSP 3 or 4, thereby meaning there was widespread paracellular involvement. The various etiologies we had come across, interesting etiologies: choristoma, gangliocytoma, 1 ectopic GHRA secreting tumor of the thorax, 1 ectopic growth hormone secreting tumor of the thorax with because of carcinoid, 1 ectopic pharyngeal pituitary with acromegaly, and some of them had McCune-Albright syndrome also, 9 of them. So this one you can see here, multi-compartmental macroadenoma, and this was operated simultaneously by our heroic neurosurgeon, late Professor K.K. Mukherjee and Dr. Praveen Salunke simultaneously. One was going through transsphenoidal route, another by transfrontal route, and there was almost complete excision. Have you ever seen such a huge tumor? We can say this is a mega-giant somatotropinoma. This was an unfortunate young acromegaly patient. He was just 17 years old, landed up with unconsciousness, and the doctor ordered one CT followed by MRI, could not find out the cause. He just found out the tumor and referred to PGI emergency, neurosurgery emergency. Neurosurgeon called us and he was found to have severe diabetic ketoacidosis, and there was a large tumor. Diabetic ketoacidosis was of course controlled, and we were thinking how to go about it. I told Dr. Salunke, who was the neurosurgeon, just you go ahead, remove one part of the brain as well also, just do a craniotomy and remove as much as tumor as possible. He asked for a death on table consent. The relatives were reluctant, and the child actually died because of coning and brainstem herniation. Unfortunate actually. I had never seen such a huge tumor. This is the acromegaly patient with bronchial carcinoid. I was a junior resident when the OPD used to be in second floor C block. People who have passed out from PGI, they know. The CT-based OPD used to be along with the chest OPD and endocrine OPD. It was a Wednesday only. I was a junior resident going with Professor Vansali, and this lady was sitting there. He asked me what could be the diagnosis. I told this is most probably acromegaly. We went to the patient and asked. He told I am having some kind of wheezing and there is a chest tumor. So I am waiting for the cardiothoracic surgeon. We approached the cardiothoracic surgeon that this patient is having underlying acromegaly because of a carcinoid tumor. So admit under us. Professor R. Muralidharan also presented it as in a staff clinical meeting. Very interesting case. She had complete cure, and we could manage to do a GHRH immunostaining by Professor Kalman Kovac, and subsequently it was published. GHRH secreting pituitary adenomas are ectopic adenomas, pituitary adenomas are rare. Further rare is growth hormone secreting ectopic tumors. So we encountered one such patient who presented with diabetic ketoacidosis, and we found that there was a mass in the chest. However, you can see the pituitary is absolutely normal. There is no hyperplasia of the pituitary gland. So that was an indicator that this patient is having most probably ectopic growth hormone secretion. And in the literature, there is secretion of growth hormone from ectopic sites like pancreas, lymphoma, and ovarian tumors are also documented. This is one of the first tumors in which we had documented that there is a carcinoid of the chest which was secreting growth hormone. And you can find out in the histopathology the typical cellular arrangement of a carcinoid tumor. Next is a somatotropinoma with neuronal choristoma, a histopathological surprise. So choristoma means a normal tissue in an abnormal site. You can see the MRI is showing a large tumor here. And this came as a histopathological surprise actually. You can find out the tumor cells and the gangliocytes which are positive for neuron-specific analyze and synaptophysin. And subsequent figures you can see there is a differential immunostaining positivity for glial cell fibrillary acidic protein on the left side or the gangliocytes, and the adjoining tumor cells which are negative for GFAP, thereby meaning the tumor cells are secreting something which is leading to production of the factor by the surrounding pituitary cells. So here you can find out there is a differential growth hormone positivity. The tumor cells are positive, however the gangliocytes are negative. This is an unusual association of acromegaly and pituitary tuberculosis. Even if in spite of pituitary tuberculosis, this patient was having, she was a lady from Himachal Pradesh, having a growth hormone level of 51 nanogram per ml, which is very sky high, and IGF-1 was definitely normal. Her immunostaining was positive for both growth hormone and prolactin. She was a young patient, and you can find out the caseating granulomas here with evidence of tuberculosis. And later on, when we probed, she gave history of weight loss of around 10 kg in last 6 months. And there were multiple retroperitoneal lymph nodes from where the biopsy was also suggestive of caseating granulomas, which were positive for AFP, and she was treated with ATT. And there is a marked reduction in the residual tumor actually. All of you know that acromegaly patients do have high phosphate level in 50% of patients, and 50% of them have normal phosphate level. If there is a low phosphate level, then you should be alert. And in this patient, you can find out there is a facial asymmetry also and multiple skeletal deformity. You can find out on the clinical photograph also. And this was a McCune-Albright syndrome patient with FGF23 secretion from the dysplastic bones, leading to low phosphate level. His low phosphate level was as low as 0.9 milligram to 1.2 milligram per deciliter on several occasions. And after surgery also, you can find out in the histopathology here, the phosphate level remained low also because there was not complete cure, and he was subsequently given radiotherapy and octreotide LAR he could not afford. As you know that there is a theoretical chance of development of osteosarcoma in such type of patients. However, this is very, very less, and we went ahead for radiotherapy. Coming to the clinical manifestations in our series, all of you know that the usual clinical manifestations of acromegaly are headache, acral enlargement, visual disturbances because of the pressure effect, and hormonal deficiency. And in female, it is menstrual irregularity. This is a common garden variety of patient with adult acromegaly. You can find out there is telltale evidence of acral enlargement, but the tumor is too small actually. You can find out there is a small paracellular component only. Cutis verticis gyrata may be one of the presenting manifestation rarely in patients with acromegaly, may be very unusual presentation. And this patient, he presented in 1998 with quadriparesis actually. There was a cervical myelopathy. So he was diagnosed to have acromegaly. He was there in the examination of Dr. Ganapati and Dr. Sujit Bhattacharya also. And you can find out the tonsillomegaly in him. This is very, very unusual. You can find out in growth hormone therapy, especially in Prader-Willi syndrome patients, tonsillomegaly do happen. But acromegaly patients at presentation to have tonsillar enlargement is unusual. I had seen only 2 cases in my lifetime. And he was quite tall, sufficing defining the criteria for acrogigantism. However, if you'll find out the tumor, there is a almost empty cilia with a very thin rim of tumor. So we went ahead with gamma knife. He required the second dose after 3 years and still on octreotide LAR. Coming to the bone and joint, this patient you can find out he presented only with PIBD-like symptoms, and you see how destroyed are the bones of the lumbar spine as well as the intervertebral disc. This is a patient who presented with debilitating spinal disease and bilateral knee osteoarthritis as well as hip osteoarthritis, cervical myelopathy, and mimicking motor neuron disease. There was complete atrophy of the muscles of his hands. This is a patient with paralytic poliomyelitis from childhood. Acromegaly happened later on. You can find out the upper limbs were uninvolved, so there is an acral enlargement, but the lower limbs there is no acral enlargement. Thus, there is a differential growth of limbs in patients affected by acromegaly and pre-existing poliomyelitis. This suggests that nerve growth factors or local growth factors are much more potent growth factors than growth hormone per se. Many of our patients presented with congestive cardiac failure because of acromegaly. So 6 such patients were published actually. At the time we were not wiser. Many of them were not able to afford octreotide LAR. But the current dictum is that if somebody presents with acromegaly cardiomyopathy, treat them with octreotide LAR, which will cause reversal of the cardiomyopathy, then subject them to surgery. One such patient was lucky enough, you can have serial follow-up X-rays, you can find out the cardiomegaly has reduced on follow-up. This is the LV angiogram here. And the lower panel shows a patient who was managed by me and Dr. Chituri Sirdhar, who is presently practicing endocrinology at Darwin, Australia. This lady presented with in-hospital apoplexy and died. We conducted an autopsy with the help of the pathologist. You can find out there is ventricular thickness is too high, and the EBG stain or elastic von Giesen stain and Mason's trichrome is showing the bluish color, which are suggestive of the interstitial fibrosis. So after that, we were more cautious, and all patients with borderline cardiac dysfunction, we treat them with octreotide LAR, then normalize their ejection fraction, then subject them to surgery. It is also found that the transpenital surgery in asymptomatic cardiomyopathy, there is a benefit. In a prospective group of 38 patients and retrospective group of 63 patients, there is a significant decrease in the left ventricular mass and left ventricular mass index, which were cured, as well as those patients with growth hormone level of 1 to 5 nanogram per ml. As you know that the safe limit of growth hormone, which is suggested by various authorities, is 2.5 nanogram per ml. So the pre-treatment hormonal profile, as usual, hypocortisolism, hypogonadism, hypothyroidism, and hyperprolactinemia are most prevalent. And following treatment, 1/3 of them had recovery of hormonal axis, and another 1/3 had new onset addition of hormone deficiencies. Various neoplasms we had encountered: colonic cancer, meningioma, breast cancer, ovarian cancer, papillary thyroid cancer, carcinoma. Now they are 5 in number. Pleomorphic adenoma of parotid gland, chronic myeloid leukemia. This is very, very interesting. I'll tell you later on why it is important. Multiple myeloma also we had encountered, and lymphoma. And recently we had encountered a patient of carcinoma gallbladder in a patient just 24 years old. He was not amenable to either pituitary surgery or the gallbladder surgery, and just a PTBD or biliary drain was put. And later on, within 2 months, he died actually because of the progressive carcinoma gallbladder. Here you can find out The Giemsa stain and the Papanicolo stain showing large, bizarre-looking cells, which are the malignant cells originating from the gallbladder cancer. In 2003, there was a publication by Dr. Vanchali and Professor Rakesh Kochar from our institute, he is a gastroenterologist, that most of our patients with acromegaly do not have polyps underlying. So we abandoned the routine colonoscopic checkup in our patients with acromegaly. However, in 2005, we came across suddenly 6 patients of acromegaly with concomitant carcinoma colon, and 2 of them were very young actually. They were less than 20 years. So we changed our policy, and I could suggest that colonoscopy should be done in all patients with acromegaly at diagnosis, and that should remain under surveillance on follow-up also. So we used for the first time in the world the multi-detector CT colonoscopy or the virtual colonoscopy, and compared it with the routine optical colonoscopy, and found that virtual colonoscopy is more sensitive in detecting the polyps in the colon in patients with acromegaly, and it can find out extra pathologies. However, the limitations are that you cannot take a biopsy if polyp is found. So you have to subject our patient to optical colonoscopy as well. So later on we changed our policy, and now most of our patients are subjected to optical colonoscopy only. Then we tried thinking the colonic neoplasia in acromegaly is because of increased proliferation of the epithelial cells, or it is because of decreased apoptosis. The patients with acromegaly have increased proliferation of colonic epithelial cells, and there is elevated level of serum IGF-1 associated with increased proliferation in the superficial crypt layer. And you can find out in the figure 2B, there is a photograph showing high Ki67 positivity and till mid 1/3, because in the lower 1/3 the Ki67 positivity is expected actually, because intestinal epithelial cells keep on renewing themselves. But if it is there towards the mid 1/3 or the surface positivity, then it is definitely abnormal. So we found in most of our patients there was surface positivity also, like the patients with carcinoma colon. However, the apoptotic markers like caspase 3, which is found in positive controls in patients with carcinoma colon, you can see full brown. However, it is sparsely positive in patients with the polyps or the normal-looking colonic biopsies in patients with acromegaly. Similar thing happened with terminal deoxyribonuclease, which is another marker for the apoptosis marker. You can find out only few lymphocytes were positive for this marker. However, in carcinoma colon, there was true positivity. Next, we came to diagnostic utility of GH, IGF-1 and IGF-BP3 in patients with acromegaly who suffer from diabetes. Because as you know, in various series, almost 40 to 60% of patients with acromegaly will have underlying abnormal metabolism of abnormal carbohydrate metabolism. 40% of them have underlying diabetes, 20% of them have underlying pre-diabetes status. So how to evaluate them? Because you know that because of the chronic stress also, or patients with diabetes, there is a increase in the growth hormone level, and the IGF-1 is usually low because of the partial resistance at the level of liver for IGF-1 generation. So we conducted this study to find out in patients with acromegaly how to go about it, which is the best criteria. Random growth hormone or GHGTT, could it be done? So we did the IGF-1 in most of them, it was low, and found that IGF binding protein 3 could be a good marker. However, one should remember that there is a large overlap between the IGF-BP3 between the normal healthy individuals as well as the acromegaly patients. So better is to control the diabetes with extensive insulin therapy and oral hypoglycemic agent, maybe sensitizer, GLP-1 analog, and you control the diabetes, bring down the hemoglobin A1C to less than 8.5% so that the glucose toxicity is improves, and you can do the GHGTT. And one interesting finding is that in non-acromegalic patients with diabetes, the suppressibility of growth hormone to oral glucose tolerance test was preserved. If you will give them oral glucose load, the GH will be suppressed in patients with diabetes mellitus without acromegaly. Then coming to the predictors of recovery from diabetes following neurosurgical treatment of acromegaly, a prospective study over a decade. Normally people believe that growth hormone is a more metabolic one, and IGF-1 is responsible for proliferation. However, we could not find this in our study. And almost 60% of them had underlying abnormal carbohydrate metabolism, and 40% of them were having diabetes, and 20% had pre-diabetes, and 46% of them had recovery even with complete cure or partial cure. And the recovery from diabetes had a greater association with post-operative IGF-1 than growth hormone. This is very, very interesting, especially those patients with discordant growth hormone and IGF-1 in the post-operative period. The IGF-1 correlates better with the recovery from diabetes. And the post-operative IGF-1 had a significant impact on recovery from diabetes, independent of age, body mass index, duration of diabetes, and pre-operative HbA1c. Next question is, how many of them you had seen a patient with acromegaly with secondary diabetes with diabetic retinopathy? I had seen only 2. So there is a publication by Professor Nalini Saha and his group in Journal of Indian Medical Association. There were hardly, and Padma Menon madam, there were 48 patients and only 1 of them had diabetic retinopathy. I had seen 2 patients and this is one of them. This patient was sent by Dr. Sujit Bhattacharya from Calcutta. So he was a 62-year-old male with 13 years of diabetes and 13 years of acromegaly, overt acromegaly, and 15 years of diabetes. Maybe his acromegaly had started much before that. You can find out there is a proliferative diabetic retinopathy, and here the optical coherence tomography, you can find out there is central serous retinopathy as well. Then we came to know what is the mechanism of diabetes in acromegaly. It is usually people used to believe that there is a insulin resistance and post-receptor signaling abnormality is there. There is abnormality of JAK-STAT and other pathways. So we did a clamp study actually, and in 10 patients with acromegaly, 10 healthy volunteers, and found out that the glucose-dependent insulinotropic polypeptide or GIP resistance is found in patients with acromegaly. And there is a beta cell dysfunction which leads to diabetes later on. If we find out the normal subject, acromegaly patient without diabetes and acromegaly with diabetes, they have similar amount of insulin resistance. We went further ahead and did the duodenal biopsies as well as sigmoid biopsies to find out immunostaining for various cells like K cell, L cell, and stained them for GIP, GLP-1, SGLT1, and found out that there is no correlation between the structure and function. Even if the GIP resistance was there and GIP level was sky high, the immunopositivity for cells was less, probably because it is because of increased turnover. Coming to now the genetic analysis. In last 10 years, we had done genetic analysis in almost 250 patients of acromegaly, and we were thinking that we'll find out various causes, but the result was not very good. And various genetic causes which are enumerated in the literature are familial isolated pituitary adenoma. 20% of them can have underlying aryl hydrocarbon receptor interacting protein mutation. 80% of them we cannot find out any cause. MEN1 were found in a couple of patients. X-linked acrozygotism also we found out. And majority of them were having somatic post-zygotic GS-alpha mutation. And some novel somatic mutations were also found. I will show you the whole exome sequencing data also. So this patient was a familial isolated pituitary adenoma with AIP mutation positivity, and he was operated. He is his actually half brother who had acromegaly at 46 years of age, given radiotherapy by Dr. Sadangi at CMC Ludhiana with complete cure, at the cost of radiation-induced brain damage, and the patient now spends most of his time with, he's completely bedbound with hallucinations, neuropsychiatric, cognitive dysfunction. And he is his younger brother who developed features of acromegaly and tall stature at the age of 5 years, came to All India Institute and operated by Professor Ravi Bhatia. And a single surgery was, in those days actually, even MRI was also not available, 1985. 1987, the MRI machine came to All India Institute. With that also, the patient was cured, quote unquote cured, because you can find out after 5 years of age also, he had a continued growth and he achieved the height of 208 centimeters, thereby meaning the disease was probably not cured. And you can find out there is an empty cella, and there may be some functioning cells which were still secreting growth hormone. Now he is having acromegaly cardiomyopathy as well as diabetes also. interesting child. One of the youngest boy who presented with acromegaly due to AIP mutation. This is the youngest boy in the world literature. So we published this in JCM, and the whole exome sequencing and the analysis was done at IOB Bangalore only by Dr. Akhilesh Pandey. And this child presented at the age of 3 to 4 years with sudden onset of headache and ptosis. There is a cephalomacule actually. Dr. Mukherjee called me to the Gamma Knife Center. Pinaki, could you diagnose this patient? I told because of the presence of cephalomacule, probably the possibility of McKinnon-Albright syndrome will be higher on the card. However, I would like to examine the whole family also. So when I examined the mother was also having an underlying cephalomacule. So this was nothing to do with the disease process. And the bone scan was also normal. And when we did the genetic analysis, we found that his paternal grandmother was a carrier. She was heterozygous, but not manifesting the disease. The only comorbidity she is having is diabetes. The father was also a carrier without any disease process. He is definitely tall, but it's a familial tall stature. And one of his sisters was also having the carrier state, but no manifested disease. This could be well explained by the phenomena of autosomal dominant disease follow a particular rule, that is incomplete penetrance. And we found that the boy was having mutation in the exon 2, and all of them had same mutation in the exon 2. This is well described in the world literature, the same mutation. So you can see the preoperative MRI, there is large paracellular extension. After surgery also there is a large paracellular residue left out. And Dr. Mukherjee felt that we should offer something else. The P53, you can find out that it is negative for the tumor cell as well as the positive control. Ki67 was very high, it was 12%. More than 2% is definitely proliferative. And VEGF was also positive. Why it is important, I will tell you later on. So this was a proliferative as well as invasive tumor, thereby fulfilling the criteria Jacqueline-Trouillat classification of stage 2B. Post-operative MRI with multimodality treatment, now you can find out there is an empty cell only. He has almost 8 years of follow-up. Now the child is not having any ptosis. There is a small paracellular fibrotic residue, but that was significant enough to increase the growth hormone and IGF-1 to sky-high level of almost 700, 800 nanogram per ml. And you know that at puberty, we do not have actually normative data, and what should be the IGF-1, we do not know. He was offered actually octreotide, bevacizumab, temozolomide, with them no control. Finally, we have to procure pegvisomant from Belgium with a import license. And I am thankful to the Pfizer India as well as Pfizer International with collaboration. Actually, Professor Matha Corbonate could arrange pegvisomant. With that, the IGF-1 came down to 149, and for last 3 years, it is absolutely under normal limit. You can find out the serial MRI, T1 weighted MRI, coronal section. There is a small fibrotic residue in the last MRI at 52 months of follow-up. This is story of a X-linked acrozygantism. She is only 4 years old. She presented with tall stature. You can find out the principal is standing left to her. She is taller than her principal. And for that, this father brought the child to us. And we found that there is features of acromegaly. And there was sudden growth actually in last 2 years. And as a part of international collaboration, we had 12 X-linked acrozygantism patients out of 153 acrozygantism patients who were having underlying X-linked acrozygantism, and most of them were having sporadic mutation actually. So this is because of a microduplication. Many of them were subjected to targeted gene sequencing, which was negative, followed by whole exome sequencing, whole genome sequencing, they were negative. But this was found because it's a microduplication or microdeletion. They are not diagnosed by whole exome sequencing because they are small spots, they are missed. So you have to have a droplet PCR or a array compatible competitive genomic hybridization for diagnosing this condition. Professor Matha was kind enough to do the genetic analysis for the child, and this was the histopathological analysis done by Professor Roncaroli from Manchester University. You can find out they have underlying hyperplasia of the tumor. So you have the silver stain which is positive, showing the reticulin fibers nicely here. And a few interesting other findings were there. They were colloid-like material. You can find out here the asterisk, inside the asterisk, like the colloid in the thyroid. This is a very hallmark of the disease process. And you can find out the calcific spots also here. And the last but not the least is they were most of the time positive for growth hormone as well as prolactin because of the co-secreting tumor, and alpha subunit of FSS were also positive. And you can find out in the double immunofluorescence that both co-localization of growth hormone and prolactin in the same cell. And fibrous body, which is nothing but a filamentous aggregates, or they are cytokeratin membrane antigen CAM 5.2. They are also almost always virtually positive in this type of tumor. You will find out in a histopathology, this type of histopathology, suspect X-linked acrogigantism and go back to them actually. It's a multiple endocrine neoplasia. You can find out there is a parathyroid tumor, there is acral enlargement, there is a pituitary adenoma and an aneurysm. However, the combination of clinical manifestation does not necessarily suffice that this patient is having underlying multiple endocrine neoplasia. I would say the more important markers for suggesting or the indicator of a multiple endocrine neoplasia will be intestinal carcinoid or the gastrinoma. They are more specific actually to diagnose MEN1, which I'll narrate you here. This lady presented with repeated episodes of hypoglycemia with coarse features to the gastroenterology ICU. She had unconsciousness. You can find out the coarse feature. We were thinking that this is an insulinoma, and the coarse feature is because of the IGF-1 acting on the insulin receptor, and this is a specificity spillover phenomena. After the tumor, the curative surgery, you can find out the tail of the tumor, tail of the pancreas, there is a tumor on gallium dotatate scan. There was coarsening was still persistent. So IGF-1 started increasing actually in this patient. So because of the diabetes and poor control, because in patients with hypoglycemia, you expect the IGF-1 to be high actually. In this patient, it was low. And subsequently, there was a steady increase in IGF-1. So we subjected the patient to pituitary MRI. You can find out there is a microadenoma. Now she had a successful cure. However, on genetic analysis and on whole exome sequencing, MEN1 was negative. Thereby meaning all that glitters is not gold. She was most probably not having underlying multiple endocrine neoplasia. These are just chance phenomena only. Therefore, I'll stress again that presence of carcinoid tumor of the gut and the gastrinoma favors a multiple endocrine neoplasia with other tumors, suppose a parathyroid adenoma, prolactinoma, or acromegaly, much more than a co-occurrence of these two tumors. This is a patient who recently presented to us with coarse features, and you can find out acral enlargement. There is a small pituitary gland and large suprarenal mass and heterogeneous density. With the help of the International Pituitary and FIFA Consortium, we could do genetic analysis in 11 of our patients and find out that 5 of them had underlying SDSB mutation, some of them had SDHC, and MEN1 also, and various other non-significant mutations also. So treatment modalities offered to our patients is, as you know, it is as usual. Cure rate was for microadenoma, it was 30%, and macroadenoma, it was only 10%. When 5 surgeons were operating, when we deputed only one dedicated surgeon, the improvement or the cure rate improved to almost 55%. So then we went ahead to find out any early marker of improvement of the growth hormones or cure of acromegaly. We found that random growth hormone value of less than equal to 1.5 nanogram at 6th hour following surgery may predict long-term cure, but it is useful only in 2/3 of patients. Another 1/3, it may not be useful. This is pregnancy and acromegaly. It is presented in the second trimester, one of our patients with apoplexy, 12 cases with 14 pregnancies and good outcome. This is the last slide. So this is a somatic variant in GH secreting pituitary neuroendocrine tumor and whole exome sequencing approach. We took the help of Dr. Akhilesh Pandey from Johns Hopkins, and we did the tumor whole exome sequencing as well as the germline whole exome sequencing. This study was funded by actually British Council, and the highlight was that recurrent somatic mutations are more common in genus rather than any other new genetic mutation. There are variants in 5 and more genes which were identified, and the involvement of the cyclic AMP and calcium signaling pathway is the most important pathway which should be targeted for whole exome sequencing. And last slide, when to do genetic analysis in young, familial, those with acrogigantism, if there is a associated high prolactin along with growth hormone and patient presenting with apoplexy in young age. But there is a catch again. This family, this is one of the family member, this is one of the family member. The father was operated at All India Institute in 2004 with complete cure. He had typical acromegaly features. The daughter presented during second trimester of pregnancy with apoplexy. We were jumping actually, this will be definitely aryl hydrocarbon interacting protein mutation. This was not. With targeted sequencing, it was negative. We did a whole exome sequencing, it was negative. So there is a lot more to be done for genetic analysis in patients with acromegaly. I am thankful to Professor Marta Korbanits and Dr. Carlos Gesto-Massuet, who are my collaborators from Queen Mary University, London. Professor R.J. Das, who is late Professor R.J. Das, and this is late Professor Kanchan Kumar Mukherjee, who died at the very young age of only 52 years at IOB Bangalore only during attending a conference. And this is one small step for a man, one giant leap for mankind, thus told Neil Armstrong. Thank you very much.
Thank you, Dr. Pinaki. That was, I think, a splendid exposition of your journey in acromegaly. Again, a brilliant example of interdisciplinary from, of course, the patients to pathology to gastroenterology to, I think, different departments across the country as well, and maybe across the globe. So I think that was very, very nice. Thank you. Thank you very much. Over to the organizers.
Thank you, Dr. Kalra and ma'am. Thank you, Dr. Pinaki, for that excellent